But one thing I do highly recommend is the breathing assessment, because if you see someone not able to move the column of air from chest down towards the belly, and rib expansion, both in the anterior, posterior, as well as the lateral, it's a 3D. We have, those 9 lobes that have to get ventilated. If you have someone who's an upper chest breather, the diaphragm is not in that much of an excursion, and the rhythm of the diaphragm, pelvic diaphragm, is constant. It's a little sine wave going on throughout the day. Yeah. And those folks are losing those repetitions of the pelvic floor in sync with the diaphragm. Yeah. So the pelvic floor becomes dysfunctional in a way. And I see down the line, I've anecdotally, I'm starting to collect data on this, is that when you have mostly upper chest, a scenario where the person is an upper chest breather, they have a higher degree of pelvic pain, because it leads to less range of motion in there, less awareness of the pelvic floor, and they can't make the connection volitionally as well as autonomically, in my opinion. So there is something that to be said about fixing the breathing. Instead of cueing the breath for the pelvic floor, I say, just stick straight with good breath control, and you're gonna get that automaticity to pop in.
And that was the same conclusion that Hadar and I had come up with when we realized, we're looking at, and we taught this fascially as well. We talk about elasticity. Like a lot of times we think of tissues as being contractile, but as you just explained, that sort of ebb and flow of the 2 diaphragms, and I would include the vocal cords as well, but the different diaphragms that are, maintaining intra-abdominal pressure dynamically based on our daily activities spontaneously in a healthy individual, right?
Yes.
And so as long as the tissues are being moved, they maintain their elastic properties.
Yes.
When they stop, and that's what I hear you saying, is when we stop moving it, we're going to lose the elasticity. It's going to get weak. It's going to, it's not going to have that normal elastic. And I think it's the elasticity, now that I'm thinking about it, that really probably is one of the best preventers of incontinence.
Absolutely.
That would be stress incontinence. So not necessarily talking about somebody having a major surgery or right after partum, but that idea, like when you talked about the just the hormonal drying out of the pelvic floor and the urethra and the sphincter, that really made sense to me to think that, well, if those tissues aren't supple and aren't moving in a normal way, just as we move our body, it's the same thing. We become sagittal beasts sitting in a chair, and we expect our back to be able to move in 12 degrees of freedom, and it doesn't. Well, it's no miracle. We've been sitting in a chair with no demand on it. Or another good example is ankle dorsiflexion. We put a kid in a chair at 4 years old, they no longer have to put load through their ankles unless you make them sit on the ground, especially as they're going through their growth spurts for the next 10, 15 years. So if they go through growth spurts and they never go down into a deep squat, they'll never have that elasticity and that mobility that we need in our ankle dorsiflexion to have healthy knees, healthy hips, healthy back. It all ties in together. And that's what I wanted to sort of bring out is, we don't have to make the pelvic floor like it's some kind of foreign Martian tissue. It's responding just like any of our muscle tissues respond, any of our organs respond. And, when we understand that, and we understand that normal breath sometimes can be the very best thing that we can do. And that people that are sedentary and people that are immobile or people that are fearful of moving, there's lots of reasons why they wouldn't move. Pain, right? They could be in pain. We haven't talked about pelvidynia, but pain in itself can stop movement, stop breath from going down low. It might make somebody with severe pelvic pain might just resort to accessory breathing because they don't want to have any displacement down there, or if they have, those kind of things. So that's really cool. We have another question. I think we've answered this one already, Christine. As far as suggesting for bladder leakage, that's the incontinence with sneezing. And we've sort of talked about just maintaining that elasticity and the suppleness, the movement, natural breath, natural movement. Is there anything else that you'd want to add to that, Pam, before we go on to like prolapse and talk a little different anatomy
So
pathology?
if, just to add in, if someone has true stress incontinence, to, for the person to actively recruit and understand where the pelvic floor is, that may need to be referred out for further, like to a good pelvic health PT who can identify where it is with the patient or with the client, and then get them to actively do that. And then they practice doing it with that intra-abdominal pressure load, during volitional activities, even ballistic movement, which ties into the prolapse piece too as well. But you're training it for, like for sneeze, I just say squeeze before you sneeze. So and that's not the butt, right? It has to be lift the urethra. So aiming for the front.